Um, can everyone hear me okay? I think Scott heard me earlier, so um, I hope to go over some information with you, but I also hope that you guys would chime in a little bit more. Obviously, Dr. Dingle talked to you guys some about the general musculoskeletal pain, so trying to figure out, some points to go off of that. If you have questions about that lecture, I listened to most of it, so I kind of used some of the stuff she said, and I'm not going over that again, but just trying to concentrate specifically about the limping child, which is a little bit different in that it could be a lot of things, not just joint pain, but teeing off some of those components of things also. So we'll try to discuss um, that stuff. So when we're thinking about a limp, a lot of it is trying to think through what exactly is a limp, and in general, it's basically just any abnormality in gait. And so this can be a lot of different things that can cause it. Some of those obviously would be the pain, weakness, so neurological issues would always be way up there too, to consider. Some deformities, so congenital stuff, especially when the kid is just starting to walk. And that's where behavioral things come into play too. You have the kid that just toe walks. Stiffness is again one of those things where it might not be as much pain, but if it's more of a chronic issue, sometimes now the stiffness is what's causing the more noticeable limp where they actually can't do some of the stuff. So 80% of pediatric limps are benign, but that would say 1 in every 5 kids that you see are going to have some problem that is more than just, they fell down and bumped their leg. The age that we see it most common is 4-year-olds, because again, that's where the age they've started to walk much more normal. And then people start noticing a big change in their gait. And most of the most common thing when you start talking about age differences and things is where we get into that transient synovitis that Dr. Dingle talked about. But obviously then we have the most common causes. So we got bumps, bruises, which sometimes aren't always known. And so that's, I think, when it really concerns parents. Will they'll bring in a kid where they don't really know where that came from or why they're having that much pain because they didn't see any major fall. So again, age-wise is always important. Looking at just skin-wise, overuse obviously is a big thing. That's kind of a whole nother talk, some of the details of overuse injuries, sprains and strains. Again, understanding the difference between those two, sprains being where you sprain ligaments, strains being the muscles, tendons, and then toxicinovitis being that other big common one that has a specific diagnosis in the younger kids. Then we go into more dangerous to miss categories. So this is the thing that's always in the back of your head of when a kid comes in, these are the things you don't want to be missing. Obviously a fracture, many different types. We'll talk about some. Obviously there's a difference in fractures. So there's the little tiny fracture that you might not be able to even pick up on versus the displaced, dislocation fracture or fracture that will get much worse if you don't treat it. Mechanical, so that's developmental dysplasia of the hip, skiffy. Infectious, spinal, so always remembering that spinal causes can cause a limp because of neurological disorders. So that's where we start talking about, and then you could go back up to the infectious and say like an epidural abscess, but obviously other spinal dysraphisms can cause some trouble and pain, numbness, tingling, which would change the way you walk. Obviously cancer, between tumors, leukemia, those sort of things, JIA, and then not forgetting abdominal causes. So again, you have like the psoas abscess is one that gets missed often because it's an infectious cause that's in the abdomen. And so you're looking all over the lower leg and there's no problem. But remember the psoas muscle, one of the hip flexors, comes up into the abdominal region. And so that would cause pain in that region that you would easily miss if you just examine the lower extremity. So I know Dr. Dingle gave you some charts to look at, and again, every specialist looks at this in a different way. These are just a couple different ways to look at it. looking at the type, just like I said, infectious, inflammatory. This one breaks it down into the vascular component. So we'll talk a little bit more about that. That's where like the Legg-Calvé-Perthes disease comes into play, but also sickle cell disease, neoplastic, congenital, and then those others where again, even pelvic inflammatory disease, inguinal hernias, those sort of things. Intracranial, obviously causing some issues in the brain would always be possible too. And then you could break it down into the differential looking at limps versus the ages. And so this is another big key to kind of put in your head. And we'll try to come back to this chart because we could obviously talk about all of these disorders. But I throw it on there because I will bring up some of these. And so just so you know, I'm not just bringing up random stuff. This is, on the list and not just super zebras, but things that you will see or that will see you, but if you don't look for, you'll miss. So if you look at this and you have specific, things that you're not sure, I will either come back directly to this slide to go over it more, or let me know if you see something and then you got questions about what that means, because I think some of these are very important, again, because they're testable questions, but also, again, trying not to miss it. And again, one of those big ones, just looking randomly at it, you see down here, there's discitis, and discitis would be that kid that doesn't want to walk. But again, you're looking at his lower extremities, it's not going to be a problem. But if you do the classic thing of bouncing him on your knee and it hurts, that's saying there's some inflammation in the discs in his back that's causing his limp. So then I break it down into some key basic history and categorized. Again, looking at the age is a big component. Obviously, kids that just started walking, you're gonna look at a lot different than someone with a brand new limp. But obviously age makes it really hard for those kids because they're not gonna be as vocal versus a 18-year-old comes in with a limp. He's probably gonna be able to tell you what's been going on in all the detail. Acuity, so obviously acute versus chronic, but also thinking of in relation to things like severity. Is the acuity like it came on strong and then getting worse, or it came on and just kind of stayed there? And as Dr. Dingle talked about, and we talked about at morning report even, there are components there that play a role, again, just the evolution of what's going on. And then obviously trying to pinpoint a location, but that is also your responsibility some. So they might say, oh, my knee hurts, but when it's actually their hip. And so trying to get some general location, but obviously that opens it up to a lot. So in that history, taking a very thorough history is going to be important from the caregivers and the patient, as we said, available. And that's where, again, where I see most things in the trauma activity world, but that's where making sure you kind of ask about it. So a lot of times we probably ask, did you have any trauma? And they'll say no, but then they play football, so they had some sort of trauma. It's just, again, what level, and they might not remember one big hit. That's also where we see concussions the same sort of way. And so then, is the limp worse in the morning? Obviously, that's one thing that we talked about with rheumatologic preceding illness. Are they sick right now? So again, putting the infectious category of high. Constitutional symptoms, night pain, thinking more oncologic. And again, none of these are like absolutes, but that's where it's just bringing up in your mind. And then again, the age where the limp, just since they started walking, that could be something that has been going on a long time and just now showing up. And then prematurity obviously brings a lot of other things into play. On physical exam, again, looking at the whole child, because this can help you a lot, figuring out if they have fever, those sort of things, but making sure you're set up to see the entire child. So this is where, as we'll talk about, making sure that you have them in a gown so you can see everything, you can have good range of motion, you can see the full joint, all their skin, help look at their spine, And then obviously doing a gait analysis will be helpful. So that's where sometimes you got to think about if you want a 16-year-old in a gown, and then you're probably not going to have her walk up and down the hall like that. So maybe doing that first, then switching to do a more in-depth. Then with the gait, looking at little kids, sometimes it's difficult because they're gun shy to walk, but that's where trying to watch them come into the room, have the mom just kind of casually be talking to the mom and have her get up and walk it with you so the child follows, but doesn't know they're being watched, are all good techniques to kind of get a good assessment of the gait. And then doing it for a while too, not just quick, because sometimes things take a little bit to come out. Looking at the joint above and below is something we always talk about, comparing sides. So really on the inspection, making sure that you see if there's a big difference. Looking if there's an infusion versus just localized swelling is a key technique. That's where you'll see examining a knee. They'll talk about like milking the knee to try to bring down that fluid and really feeling in the joint line. So again, where you're palpating, where the tenderness is, because some kids it'll just be tender all over. Sometimes you'll find that really sweet spot right in the joint line, right on top of a bone, knee place. And then range of motion, passive versus active, is always one of those things you want to key in on too, because that helps you how they're holding it. As I'll show you some pictures, can be a key. And then whether or not it just hurts for you to move it versus them moving it helps you kind of key through the difference between it being joint versus muscle. And again, can be very difficult, but that's where trying to think through all that stuff as you're examining, so you don't have a kid that's just crying and refusing to do anything for you, because then you kind of lose, again, that big key component that helps you a lot in the physical exam. And then, like we said, examining the abdominal area, the spine, the GU, so testicular torsion being up there, ovarian torsion, things that are causing pain that then they're limping, not necessarily because of lower extremity pain, but just because of the way when they walk, they hurt. And then we get into the special tests. So all of these tests are something that you do every day, and it's not that difficult, but I think add a lot of value. And so this is where the special tests are the ones that have the special names and get confusing, and everyone always says, well, I forget, and so I don't really know. But I think knowing some of these basic ones then are in our mind help key us down, thinking, okay, just like with the knee, okay, they come in, you can isolate it to the knee, what is problematic, using your anatomy to guide you, but then your physical exam, exactly where is it tender, feeling on the patella, again, you can push on the patella to see if they have laxity there, a guarding sign, testing the ligaments, McMurray's, like Dr. Dingle talked about, she has to do that sometimes to try to look in, is it a meniscus? Is it related to that? Again, sometimes if you do a McMurray's and it's positive because of pain, that doesn't necessarily mean anything. It's pain specifically in the joint line. So exactly where you're palpating, where you're asking them, it's painful. Just like a straight leg raise isn't just pain in the back, it's the radiating pain. And then the hip, which is more difficult to examine, I usually start with a log roll. So basically just laying them down on their back and then just taking their leg and rolling it a little bit to try to isolate. So again, now you're not moving as much, but it's really looking at just the hip movement. The Galeazzi sign, which I have a picture of, which is again for younger kids, like the difference in the height of their leg laying down. The Favor test, looking at SI joint. And then again, abdominal specifically in there, trying to look for masses, inguinal. Again, I kind of think of these as specialty things because if you don't think about doing it, you're going to miss it. In the spine, again, straight leg raise, looking at radiculopathy, like I was saying with discitis. Sometimes they talk about just bumping the table and seeing if the kid reacts, because then that tells you there's a lot of inflammation in there that could be more discitis or things like a septic hip. So just a couple pictures so that we have one girl laying down on her belly, and then you see the range of motion in the hip there, which is sometimes an easier way to get them to relax and see the difference in comparing sides. And you see below where now she's trying to relax as she can't with that hip. And then the Galeazzi sign where you see that difference in the height. And so again, that could be looking at developmental dysplasia of the hip where one is now had been off and missed, or things like Dr. Dingle was talking about with JIA where now you have growth disparity, but now you have a definitely limb is different. And so this is where obviously their gait could be off because one limb is longer. So that just helps you bring it into that context. And then the Faber test, or also called the Patrick's test, so is where we try to isolate into the hip SI joint area. So the word Faber is for the flexion, adduction, external rotation, and trying to see if that causes pain. This again is another extensive thing, but what this is looking at is exam findings. So you've done a good exam, but you find something abnormal. What does that then equivalently as a possible underlying condition? So you see the first one is just abdominal mass. So again, obviously abdominal mass changes it. But these are again something we could talk extensively about each one. And some of them are the very common ones that obviously if you see a malar rash, you're going to think of lupus, but something more subtle, like I'll show you in a couple of pictures where you have those positive tests. Now you can isolate, think more into that, even come back to your more exam, now isolating it onto those type of problems. And then things like swelling, atrophy. Obviously atrophy goes more along with a neurologic disorder or not using. So again, the chronicity component of things. And then rashes and skin findings can be a huge thing too. And if you guys have questions, feel free to chime in, but we'll go over some more picture things. And I definitely, if you guys could speak up a little bit on some of these to kind of tell me what you guys are thinking. So this is a kid that comes in and basically is saying they're having a pain, but you see you're looking at the exam, comparing the two sides of the hip, and you see on one side you're just trying to flex the hip up and they come up normal, but on the other side you're flexing and you see this like rotational component of things. Does anyone know what you would think about in this case? So if you have, basically this is obligate external rotation of the hip.
Skiffy?
Skiffy, good. Yeah. So this is one of those where, again, if you look at the details of it, this is where the skiffy is mechanically, that cone is falling off or the ice cream's falling off the cone, and that's what makes them rotate out. And so this would be, this is where a kid comes in for knee pain, but you see this on your exam, then you're obviously going to now get x-rays of the hip versus x-rays of the knee. And this is vital to not missing this. Does that make sense, everyone? So that, and then if you had looked at that list of that chart before, that was one of the things. If you see hip obligate external rotation of the hip on flexion, then skiffy would be number one on your differential. But then if you have another kid that comes in like this and is laying there like this, and then obviously just doesn't feel good, what sort of things are you thinking on this one as far as what's going on? Like, what do you see? What do you observe? And then what are you thinking as the cause? So what in general is this at least telling you? So this is kind of, again, being very observant to how the kid is before you do too much to them. Does anyone know what you would say about this child?
Is it supposed to be the same picture? Because I don't see a picture.
Oh, is there nothing there?
No.
Okay.
Or at least on my screen, maybe other people's screens.
Is it just like white?
No, it's just you.
Oh. Can you see something now?
No.
Okay. It's just me again. Let me get back into. Maybe I stopped sharing. There we go. Can you see it now?
Yes.
And is it in full screen or is it like?
It's in full screen now.
Sorry. Now can you see it?
Yes.
Okay. So what would you guys say about this? Like, and it's again one of those, in the test question they'll give you, the kid is, you see this, and then the kid doesn't feel, comes in because they didn't want to walk, and then the mom is saying he just doesn't feel good. And then it could ask a number of different things of like, what's the next step or what the diagnosis is, those sort of things. But what would you say you see here? And I think that's the key part to think about.
Transient synovitis.
So transient synovitis would be up there, yes. What would be the one thing that would, what are you seeing that's making you think transient synovitis? And of what?
The fact that the kid won't walk and that there seems to be hip involvement and the age of the child, but it also could be like a monoarticular JIA.
Yeah. So I think that's a good thought. Then that's where this picture kind of goes a little bit more, because remember with transient synovitis, it's more just a little bit of pain versus just frank, I don't want to move my hip. And this is where it's key to understand that this person is holding their hip in the position that actually makes it the joint the biggest, so it puts the less stress on it. So definitely you could say there's a problem in the hip, and then this would really increase the likelihood of it being septic arthritis if they don't want to move it, and that's where it's just like super painful to move. So transient synovitis definitely being like one of those things that you would think of, and then common things being common. And then so what would you do if you're thinking transient synovitis? What would help differentiate transient synovitis from septic joint of the
You
hip?
can check like an ESR and a leg count, and you'd expect the kid may well be febrile of the septic joint. They might not be with transient synovitis.
Good. And so I don't know if you guys remember the COCAR criteria, but that's exactly right. Where over here you got the different 4 criteria of not wanting to bear weight, which puts up, again, and that's what you'd kind of say with this kid is he doesn't want to bear weight. And that's where he gets into that. Does he not want to, or can't he? And so if he's laying like that, he's kind of giving that away of like, I want to hold my hip this way because this is the most comfortable. And then the fever, the ESR, and the white count. And you see if you get a point for each of those and you have 0 points, you have a 2% chance in one study. But if you have all 4, you have a 93% chance of having a septic hip. So again, this is where you can use that information to decide, am I gonna do more? MD Calc has a little thing where you just click on these and it would give you a little bit more data on that too. So always looking at those criteria and using MD calculators to help guide you a little bit, so you don't have to remember the exact percent. You just go and click, okay, this is what they have. And then you see that most are under 2 years old or in the hip, and then the other big place would be the knee. And then I also put in a chart about the different, because again, that's where they might say what's the most common cause. And you see this is where strep aureus, or staph aureus, sorry, would be up there, and then strep being behind it. And then Stallworth always likes to ask about Kingella kingae, which you can see in that 3 to 3 years old is up there also. And just another thing that doesn't get cultured. So again, if someone goes in and cultures it and they're, an adult orthopedist somewhere and they're like, oh, it's fine, I didn't culture anything. That's where making sure that you understand some of those premises. And I think like we talked about with the SCFE, this is an emergency, and again, a lot of that has to do with here, you're damaging cartilage every every hour that goes by that you're not treating it as the infection lives in there. This would be, because some people would say get an ultrasound, and actually ultrasound would not be the differentiating point between transient synovitis and septic hip, but more, let me see if there is actually a problem. And so you can see in this versus the right versus the left, you see a big difference in the effusion around the femoral head. Does everyone appreciate that? And so that's just one thing that then now using ultrasound not to make a diagnosis, but helping to streamline your decision process of this person definitely has an effusion on the left side. And you don't have to be a great ultrasonographer or radiologist to look and see there's a difference between there's a bunch of black stuff around the left one, there's not about the right one. But again, you have that, the way he's holding his hip, your exam, and this would just add a little bit more information. And I think this came out a little bit blurry, but this was just, again, looking at the difference between doing like the hip evaluation. So the thing between a sick child and not being sick, and then your evaluation, where this is where saying an ultrasound, again, just to see if there's an effusion helps you really, because now if you have an effusion and he's sick, like that skyrockets up. If he doesn't, then looking more, and then you always see like the progression of thinking through x-rays, and you see these two big things, toddler's fractures and Kolar disease, which we'll talk about. And then again, where the ultrasound just kind of helps guide you a little bit, and especially a bedside versus a formal one, because again, ultimately, if you think they have that, you know, that's where getting orthopedic involved for definitive treatment. And obviously MRI is down there when you all of a sudden can't really figure it out and you want more information. So I wanted to show these 3 different cases. This was one article that I had seen about the approach to a limping child. And these are kind of like outside my normal expertise, but go along back with that kind of case like we were thinking of, where you have one kid that comes in, a 3-year-old comes in with 10 days worth of things, so very similar, no trauma, nothing recent that they know about, and then everything you look at looks like pretty good. So what are you thinking about doing here? And kind of thinking through the same similar case, again, these kind of comparing, contrasting, where you have another kid in the other emergency room that you know the room next door with who's 11-month-old, refusing to crawl, low fever, a little bit of a rash. They're afebrile when you see them, but you do see the rash. Bilateral knees are swollen. There's no warmth, and then you had pretty good motion, but you know, what are you thinking about here? And then again, another one is a 2-year-old healthy girl that's refusing to walk. She has runny nose, cough, normal exam, refuses to bear weight, no joint swelling, no tenderness, nothing you can see. So again, all of these are like, there's something there. Well, what are you thinking about as far as what we could do to help tease this out? And you can see where the history is a little bit different in all of them. But you can also see it's very like nebulous of, yes, a little bit of runny nose, cough, which all kids had, a little bit of fever, a rash, you know, is that a viral rash? Do they have a virus? Does anyone have any thoughts about things you would want to think about doing, examining, asking more questions, that if you had all these cases trying to figure out the difference? Because I'll tell you, one of these is really bad, and one of them, and the other 2 you would send home. Again, this was just them taking some data and looking at, thinking through using all this information, but seeing how it can kind of get very blurry. But then you start building your case, and then all of a sudden you do something, and then boom, now you have you're kind of going down a different branch point. Does anybody have any thoughts? And again, things that you would do or things you would be thinking about. And it kind of goes back to what we were talking about at morning report, just thinking through the differential and then having to kind of make a game plan because, this is where none of these people scream out like call ortho, right? And so none of them scream out get an x-ray because there's trauma, right? So kind of the more common things that we think about doing. So then you're kind of in the back of your mind thinking, well, what else would help me in this situation? And basically the article was again using these three, and then they said basically if you get a CBC, CRP in all three of these kids, and you get them all back, case 2 comes back normal, basically like slightly elevated. Case 3 comes back slightly elevated. So 3 is kind of an easy one, like you were saying, transient synovitis. Okay, here's some NSAIDs, you're good to go. Everything else being equal. 2 gets into that serum sickness standpoint. So serum sickness being something that, again, is not like I have a great thought, like, but then you again are just ruling out some crazy issue. But then 1, which again comes in just with nothing, comes back and their CBC is 50,000 white count. Now you have a problem, right? And so this is where this kid, case 1, is leukemia. And so that one obviously is a big difference between the other two of more assessment and send home with close follow-up. Does that make sense? Is everyone still there? Everyone fell asleep? I got a thumbs up, good. So the next few too, if you please chime in a little bit more, because they really are just based on the case, and I'm just trying to get what you guys are thinking. And again, this is the whole point of that one was not just like the diagnosis, it's more about thinking through. And then this one was a 12-year-old that presents to the orthopedic office with a referral from their PCP for a limp due to pain in their lower extremity. Now the problem with this case becomes that whole, again, I'm never going to hold it against someone to just refer someone because you want them to have better treatment. But this is a good case of where that is actually not going to happen. But this is where the initial assessment, now I would hope that you'd be able to do at least some of this stuff because this patient had no diagnosis or education. So again, there was nothing in the note that even kind of said what they were thinking or what they knew it wasn't, right? So they didn't even say like, I don't think this is cancer, or I don't think this is leukemia, which I think would be an important thing to start. Again, maybe not that you're going to know that for sure, but some of the basics idea of like narrowing down your thing. So when you're saying you're referring to the orthopedic, you're not just kicking it over to them. You're saying, I'm thinking through this and this is what I'm thinking. But they also had no workup, so not even looking at what problem it was. So they didn't even define where the pain was. So this is a 12-year-old, so you should be able to localize it on your exam. And then no treatment. So again, this person had no components of helping them before they were sent to the orthopedic office, where I happened to see them. But they could have seen any orthopedic surgeon for this problem. And so I'll come back to this case specific, but I wanted to go over a couple things that you could have thought through at least. So again, this is where looking at flat feet. So if the foot was the main cause, which if you did some exam and teased it out, you would have said, well, it's your foot that's the main problem. But this is where looking at the difference between flexible flat foot and rigid flat foot. And you could look back at some of those charts, and one of the big things, I don't know if anyone knows what if you have a rigid flat foot, what the diagnosis is that causes a limp and pain that's high up there that you don't want to miss, versus the flexible flat feet, which a way to tell the difference is have them stand on their tiptoes and you see how the arch comes out. On a rigid flat foot, when they do that, it wouldn't actually come out. And that means there's some rigidity to it. And there's a common diagnosis that sometimes on the exam, they'll try to get you to figure out what that is. And it's in that chart of a limping child. Does anyone know what that is? So it's a tarsal coalition. So that's where you have the tarsal bones in your foot are connected with either like a cartilaginous or bony connection. And so it usually comes out as the kid is skeletally maturing. And so they'll have pain in a rigid flat foot. So this is an x-ray that maybe, again, you figure out it's a foot and you decide, well, I'm going to get an x-ray just in case. Can anyone describe what you see on this? But I think this is where it's important to know look at some normal ones, but then also trying to figure out what you see abnormal. And then again, not that I expect anyone to look at this and tell me a diagnosis, but more tell me what sort of things you're thinking. And so this helps drive your plan better.
It looks like there's extra bone and maybe some type of lesion
And where is that?
on the big toe.
So you're talking about, can you see my pointer?
Yes. So that white thing that you're pointing to, that maybe some kind of lesion. And then the thing, if you go to the right, right there. Yes.
So does anyone know what that is? So that's where I was saying, like, knowing that you've looked at some x-rays again, because that's actually a common thing that.
Sesamoid bones.
Someone said it?
Sesamoid.
Sesamoid. Good, Keith. Did I teach you that?
You did.
Okay. I think you knew it the first time though. I just reassured that your education. But yeah, these are sesamoid bones. So this is where you have a little bit, and it looks kind of funky because of the view. And so you always got to be ready to look at, but those are your two sesamoid bones, which we could get into the weeds again, where you can have sesamoiditis, you can have fractured sesamoids, you can have a bipartite sesamoid. So there's a lot of weird things you can have, but those are sesamoid bones. So that's actually not the problem on this x-ray. And again, would tell you where was their pain on the ball of their foot, right? Then you're looking right there, and then you would say, okay, well, that's, sesamoiditis or something like that, and you're looking for a fracture there. But this would be where their pain would actually be more lateral.
So fourth toe looks like
Yep.
there's some sort of maybe a puncture wound or a foreign body or something, and it's rather swollen.
Something there, right? Like right here is what you're talking
Yeah.
about?
Yep.
Yeah. And so that would be good to come back and say, did you have a puncture wound, right? At some point. So this person actually did like a few months ago. So what is this actually?
It's a foreign body that's stuck in there, a shard of something.
So
Or an abscess.
or you're getting closer.
Dang it.
All possible. But now look at the coloring and what's around it.
Oh, is it bone that's growing around it?
Right. And what would be inflamed bone after a puncture wound?
Osteomyelitis?
Yes, perfect. So yeah, those are all possible. Like, and again, that's where now you've built a differential, and that's different. Like again, from what your plan of care is going to be. So you're probably going to work them up, investigate a little bit more. But yeah, this would be osteomyelitis, and this again is just one of those random shots that they put in the articles to show you of just looking for little things. But a more common one that I had was similar kid comes in again, where that one, they didn't just come in and say, I had a puncture wound months ago and help you. But so sometimes you get far down there and then you see something, and now you got to come back and ask. This again is one of those, now you see those sesamoids again down here, right? And so those look okay. And then this person just comes in with a little bit of like, my toes bother me, limping. Does anyone notice any abnormality here?
Bilateral hammer toes.
So
Whether it's a hammer toe or a fracture of the second toe.
good. And those are actually very good thoughts, but neither one correct. So what would be the other possibility?
Are their shoes too small?
So that, I mean, again, that would be like you start looking and then you look back at their toe and then, yeah, a hammer toe would go with shoes being too small and pushing on it. A very good thought, but this is actually where, say they wear good shoes. It's just another thing. And this is where it throws you off a little bit here because again, it looks normal, but then you look over here and it does look more like a hammer toe. But if I told you it's not a hammer toe, it's something else, does anyone know what that would be? And I think this is where it confuses you because you would hope that they would have told you something. But this is where now knowing all that, you start asking and you're like, and then you worry about a fracture. Like, did you hit your toe? And they say, yeah, they bumped it on like the table. But instead of like directly on, they kind of bumped it like underneath the table and pushed it.
So is it like dislocated essentially?
Yes.
Yeah.
Yes. So this kid had dislocated their toe about a month ago. So again, not something you would expect to come in and just be like old dislocation, but this is one of the kids I saw at DJJ was like this, and so then teasing that out because the treatment would just be trying to get it back into place. So we numbed him up, did a digital block, and popped it back in, and he was good to go. But that's where you're kind of looking at the X-rays, where what you're looking for, because and this one actually the radiologist just read it as normal because they're looking for fractures or big things, and they're not looking specifically at the second toe, so they kind of can throw you off. But why it's important to kind of know just generally when you're comparing stuff, what is abnormal, so you kind of get a sense. Then you could Google it to get more details, or send that picture to me of saying like, this doesn't look right to me. What do you see? And then going from there. Does anyone see an abnormality here? So this would be a younger kid coming in. Again, this was on multiple slides as a possible diagnosis, but again, not something that you guys probably know the exact diagnosis, but this is where I'm hoping that you kind of understand to compare and can kind of tell me what's going on. And then this would be something where you could Google and get the answer. Does anyone see any abnormalities in comparing the two sides? And if I said it was in the midfoot more than anywhere else was where the pain was.
I mean, the lunate bone on the right side kind of looks a little bit more opacified than on the left.
You're talking about here?
Yes.
So that's the, and that is that the lunate bone?
Probably not,
Yeah.
considering your tone.
But that's a good, you're exactly right with the thing. And then if you Google lunate, you'd see it's in the wrist. This is the navicular bone. But you see the difference in the coloring. So this is more, does anyone know how you would describe this? As far as like medical terms versus just like more bright? And part of that is because it's thinking through the category of things, and you probably know an equivalent category of this, just you never learned this specifically because it's like more in depth on just like Osgood Slaughter's, but you don't necessarily know Seaver's disease as an apophysitis. This is where this is the Kolar's disease. So it's kind of a osteochondrosis. So it's just more sclerotic. So, and then most of y'all know more of the common ones that you see. But that again would be something you'd be putting in the differential. Can anyone think of anything else that you would want to look at? So say you end up getting an x-ray in this kid and it was normal of their foot. Can you think of just anything outside the box? And some of you kind of already thought about it a little bit, what this could be. And I'll tell you that, and then thinking back, if I said, again, when you're trying to think through of what you could have missed, and I think the biggest problem with this one was kind of the person that saw them just kind of gave up and was like, foot pain, I don't know how to do that. I can't do it. So they kind of just pressed on their foot and said, oh, they have some pain. But then they didn't have them take off their socks and didn't look at their foot and see this. So what is this?
Is it a plantar wart?
Yes. So this kid got referred to an orthopedic surgeon for a plantar wart. And you know, this again, when you kind of delve more into it, it's like they didn't know what that was, but it hurts really bad because you see like the blister below it. So there's a callus and there's plantar wart, and then there's a blister below it. So again, why a good physical exam is important, but also feeling like, okay, I can get some information and figure it out. Again, luckily they saw me who was able to treat it versus an orthopedic surgeon that would kind of throw the referring doctor under the bus. Hopefully not though. This, I just wanted to show you a couple other x-rays to kind of think through some other things real quick. So this one would be, again, ankle pain. There's two big diagnoses that you'd always be getting an x-ray for, again, fracture-wise, certainly. But if the x-ray kind of comes back as grossly normal, and so if you look at A compared to B, it's actually after treatment. But if either of these, actually you could look at B and say, if this person had a diagnosis that the x-ray is read as normal, but they have a pretty substantial injury, this is where two important things to remember about is you see the open growth plates. So this is, again, understanding where growth plates are is important. So if they're tender to palpation over this growth plate at the distal fibula, they could, instead of spraining their ankle, they actually sprain the physis. So remember, it's soft. And so does anyone know what a injury through the physis would be? The name of it, and if I told you it was a fracture, but it has a specific name.
Salter Harris.
Good. And then which type? Because on the test they'll put type 1, 2, 3, 4, and 5. So
I'm
you'd be
just
like, oh, I knew
guessing
it.
type 3.
Say it again.
I'm just guessing type 3.
So does anyone have a more definitive than just guessing?
Well, okay, so type 1 is usually like squished, and that's kind of what that looks like to me.
Yeah, so 1 is straight through.
Oh, 1 is
so
straight, so 4
yeah.
then is squished, right?
5.
5, okay.
There's
Yeah.
5?
I was thinking there was 4. The last
So
one.
5 is rarely ever shown or tested because it is the crush one. And
Yeah.
so use the word Salter to remember it. So S for straight through,
Oh, yeah.
A for above the joint. So remember they could flip it. So it's always away from the joint. And then L is in the lower part. So like it would be below as it comes down below. And then T is like through. So like both coming up above and below the growth plate. And then ER for crush. But yeah, Salter is type 1 fractures are those like things that are commonly missed. So that would be something that, again, a skeletally immature patient that comes in for a limp, sprains, strains would be in there, but then Salter is type 1. So that's a clinical diagnosis and can be missed, but helpful to kind of remember it. This is actually showing a picture of an OCD lesion, which is another common like osteochondritis dissecans, which in A is before they actually have to, for this one, they go in and like drill and make it grow, but you can see the difference between A and B. And then like, it's basically like a little scooped out thing. This is just, again, another PED specific cause, but why you would be getting an x-ray in a kid with like chronic ankle pain because they might have something like an osteochondritis dissecans or OCD lesion. And then I just showed you a picture because it also can happen in the knee. So again, this is one example, and then you can see it can come off and become a foreign body too, so that you can get locking, popping, catching, similar to a meniscus tear, but be actually a OCD lesion. This X-ray is another one in that chart that is something, again, comparing, contrasting. This would be where I'd hope that you would notice that there's some bowing there. So that would kind of where you would hopefully you'd appreciate the bowing that's happening on the patient without the X-ray. But you see this, then you start seeing here, and so this is where you could Google bowing leg, unilateral knee. This is actually beaking is what they call it on the X-ray. Does anyone happen to know what, if you saw obese kid, bowing of the legs, painful limp on one side, it's kind of like the diagnosis, kind of like skiffy, but for the knee, as far as like in the stem of the question. Does anyone know what that is? What's called Blount's disease. So again, just a very specific thing that's in that. Again, if you look back at those lists, it was one of the ones in there multiple times because that could be something that is, again, something you don't want to miss because this progresses pretty bad and needs to be surgically treated most of the time. Here's another picture of a knee. And then this would go along with actually something Dr. Dingle talked about, but does anyone know what would be going on here? So again, looking at grossly thinking about what abnormality you see, comparing it to, again, if you've seen normal knees, which again, looking at this, there's not an OCD lesion, but you kind of see here how things are flat. And then you see here, not so flat. This is kind of up. So does anyone know what would be, this would be indicating that this kid has? And this is something that Dr. Dingle specifically talked about. So what lives right here? And then what's like abnormal about it? Yeah. So this is this would actually be the
lateral discoid meniscus.
Perfect. Perfect. I knew someone was paying attention to Dr. Dingle. She was a good teacher. So this is this would just show you, because this is like a chronic one where over time that discoid meniscus being, instead of scooped, more prominent is not letting the bone grow. So that it's something that, again, this X-ray is just to show you something is abnormal. You wouldn't have to necessarily see this and say, oh, discoid meniscus. But again, where it puts into that kid that's not going to get better with just resting and NSAIDs. This one I just wanted to throw in there because I think we had done this question on the board review about a spiral fracture, and this one is again just showing you it for the toddler's fracture, where you, to appreciate it better, I just kind of outlined it there, where you actually don't see it on the AP and only on that lateral you see it. But if you kind of see where the red is, then you go back and look and you can kind of see a faint, again, where they'll describe it as a spiral fracture, but this is the classic toddler's fracture where this kid fell, and it's not child abuse, but a very common type fracture. And again, one of those common ones that you could see a limping child come in without like a history that he just like jumped off his house or something like that. But this is just the way that they fall sometimes causes that. This again is Skiffy, just not Skiffy, but Legcath-Perthes, because I think she showed a picture of a Skiffy, but I just want to show Legcath-Perthes, which again is in that realm of the Kohlers, where you see just like things are, the bone is just not healthy. Again, something to pick up the differentiation. This is one I wanted to throw in there just again in my sports medicine world, where this one is a kid that comes in having tried to jump and felt a pop. And I don't know if a couple people might have seen this with me on adolescent, or I brought it up, but I wanted to show everyone where you get this X-ray and it was actually read as normal, But I luckily was able to do an ultrasound in that area and see a big difference, which I'll show you. But this is, again, thinking through, this person is skeletally immature. As you can see just at the very top, you can see the iliac crest is open. And so this would increase the risk for avulsions. And so you see this little sliver here, which on this x-ray is not very good. So I got like a stock one to kind of show you what it normally would look like, or they would show you on the test. And you can see there where it's pulled off. These are all little sites where it can get pulled off. So always remembering avulsion fractures is a possibility. Key areas that you would want to look at, because again, the radiologist did not help us on this one. But I knew it was there because the ultrasound was obvious. So this is the normal side on the top. And then at the bottom, you can see where it clearly avulsed off on that anterior superior iliac spine. So this usually just, again, is an important thing to tell them about resting longer, and certainly referring for further evaluation. Most of the time, if it's not pulled off a lot, you don't have to do any surgical intervention for it. And then this is just, again, another flow sheet to kind of think through all the stuff we kind of just talked about, but just trying to take that of like, okay, I examine it, is there overuse or not? If there is, you start getting into this area and see this is where osteochondritis dissecans comes into play, toddler's fractures, where you're getting an x-ray to really look at those things. If not systemically, then you start doing the workup of the labs. Then those kind of help guide looking at what's going on. And again, kind of using those and then building it where we're used to doing physical exam, then doing that, but kind of connecting the dots over time. And kind of coming up with the game plan. Again, this is talking specifically for assessment, but at the same time, that's part of what we want to do is not do just MRIs on everyone with knee pain, because sometimes it's as simple as they bump their knee. So this is just generally the same sort of things we already talked about, being benign most of the time, but more serious is something we don't want to miss. Using our history and physical laboratory helps us. X-ray, be able to read yourself, and I don't mean like in perfect detail, but just like we did today, comparing, contrasting. Always understand that just understand the developmental abilities. So if you get a kid in there that has a fracture, don't forget about child abuse as a possibility of those limps. Again, just don't have it as don't call DSS on someone that their kid just tripped and has a toddler's fracture. But always think about it and put those together. And then always those other etiologies that are common, and extremity pathology is not always the source. So referring them to ortho may be delaying in the care if you don't really assess them very well. I wanted to throw in one thing in here about food insecurity. We've talked about this a lot. I just wanted to throw it in there because I just had another meeting, and to just since you guys are having to listen to me talk about that there'll be a survey and just about kind of like your thoughts about it. So if it's something that would be very important for y'all to fill out, that all the other programs in North and South Carolina are doing. And then I just wanted to show you a resource that I came across with more talking about it through the AAP and the FRAC about this, again, trying to ways that people can, talk about a prescription. It's kind of like that fun way, like with a prescription for physical activity and eating healthy, but this is more about the free availability of things. So I just want to throw that in there. And then coming back to those diagnoses, you can again see where I'm not making up some of these things as being super rare, but Blount's disease being in there, the Kohler's disease. Again, you can get into a lot, but I think for the most part, we kind of covered all of this between doctor, and this is where the Salters type 1 comes into play, and then acute being up here, being high in this 5 to 12-year-old range. And then a couple of resources like the ortho bullets and bone talks are just more where you can get more information. The bone talks is more like if you want to read more on a topic, they kind of, some of the pictures I used is from them. They use like funny pictures to describe stuff. Ortho bullets is more of like a orthopedic thing, but it's a good thing to read because they'll give you more guidelines on like, okay, well, if I did find this, do I really do much? And so like a Saltaris type 1 fracture, you could read in there of just splinting them, casting them, or even splinting them, NSAIDs, crutches, and you don't have to necessarily refer them. Any questions or thoughts or cases that you might, clarification on any of the cases that we've talked about, or the questions that the board review questions? And if not, feel free to let me know in the future if you come across anything. Obviously, there's other areas that we could talk more about, and I think in the future we'll do some stuff on like congenital things. And then obviously there's the actual fracture component of reading x-rays and stuff like that. But I think this generally is, there's a lot of resources out there too about the limping child. And the reason is because it'll come in and because it's so vast and it could go so many ways, you don't want to just x-ray it and then say, oh, you're good to go, type thing, or just referring straight away. All right. Well, thank you all for participating, and hopefully everyone stays safe around the holidays. Take care.
Thank you, Dr. Holloway.
Welcome.
Thank you, sir.